Good morning everybody, and today we're going to discuss parathyroid disorders. As usual, if you need to email me on this email address here. Right, the objectives for today's session include describing the types of hyperparathyroidism, describing the clinical features diagnosis of hyperparathyroidism as well as the clinical management of hyperparathyroidism, describing the types of hypoparathyroidism as well as its clinical features, diagnosis and complications, and of course explaining in detail the clinical management of hypoparathyroidism. So the parathyroid gland sits on top of the thyroid gland, and they are small pea-sized shaped glands. They regulate normal calcium levels, and their major diseases include hyperparathyroidism and hypoparathyroidism. Calcium causes muscles to contract. Parathyroid gland secretes parathyroid hormone, and changes in calcium levels are linked to the secretion of parathyroid hormone, and parathyroid hormone causes calcium to be released from bone. Therefore, in the case of something like hyperparathyroidism, you would get what we would consider to be brittle bones or decreased bone mineral density as a result. Hyperparathyroidism, you get primary hyperparathyroidism, which is characterized by chronic, poorly regulated, excessive secretion of parathyroid hormone, which leads to hypercalcemia and is present in approximately 0.1% of adults examined, can occur at any age. It is more likely in women than in men, and is more common in people over the age of 50 years. You also get secondary and tertiary hyperparathyroidism. Both of these occur in patients with chronic kidney disease, hyperphosphatemia in chronic kidney disease, and decreased renal production of 1.25 hydroxyvitamin D3 initially produces a decrease in ionized calcium levels. In this particular scenario, parathyroid hormone is then stimulated, and when parathyroid hormone is stimulated, then calcium is released from your bone, and this is known as secondary hyperparathyroidism. An alternative is where the parathyroid hormone enlarges and becomes its own autonomous organ, in that it then releases parathyroid hormone as it needs to, and this is known as tertiary hyperparathyroidism. Bone disease is seen in this setting, and renal osteodystrophy is the common clinical presentation of this bone disease. Secondary hyperparathyroidism develops in patients with vitamin D deficiency. Hyperparathyroidism is caused by a hypersecretion of parathyroid hormone. It can be caused by a single parathyroid adenoma in approximately 80% of cases. It's less common in hyperplasia of two or more of the parathyroid gland, and that accounts for 20% of hyperparathyroidism. It very frequently is accounted for by carcinoma, which is less than 1% of all cases. In patients younger than the age of 30, it's usually a multiglandular disease in 36% of cases, or in 5% of cases it's as a result of a carcinoma. The size of a parathyroid adenoma correlates with the increase in serum parathyroid hormone levels. That means the larger the size of the adenoma, the higher the increase in serum parathyroid hormone levels. About 10% of cases may be familial, and the hyperplasia of the parathyroid gland may be as a result of the men's type 1, 2A or 2B genes. These are genetic differences and have different prevalence rates. Men 2A, for example, is far less frequent than men 1. Familial hyperparathyroidism can occur in hyperthyroidism jaw syndrome as well. Now, the clinical features of hyperparathyroidism, one thing that is often discovered is hypercalcemia is discovered incidentally on routine labs. Patients may often be asymptomatic or have very mild symptoms, which is why questioning about these symptoms is extremely important. Parathyroid adenomas are usually so small and deeply located that they are generally not palpable on examination. Symptomatic patients are said to have problems with their bones, stones, abdominal groans, psychic moans, and fatigue overtones. This is just a nice way of giving you an idea of all the potential possible symptoms that the patients may have. Different manifestations depend on the different clinical circumstances of the patient. Skeletal manifestations are usually as a result of low bone mineral density that is typically found in the distal 1/3 of the radius. Lumbar or trabecular spine density is usually spared. Postmenopausal women are prone to asymptomatic vertebral fractures, which may be the first indication that they may have hyperparathyroidism. Significant bone demineralization is uncommon in mild hyperparathyroidism, right? Osteitis fibrosa cystica is present as a pathological feature, a pathological fracture or cyst of the jaw. Patients sometimes experience arthralgia, particular and bone pain, particularly in the legs, and this by far is the most common symptom that patients experience, and that's why they say bones. For example, here in this particular statement here where we say bones, stones, abdominal groans, well, bones is usually the bone problems that we're talking about, and most commonly it is arthralgia and bone pain, particularly involving the leg. In terms of hypercalcemia manifestations, mild hypercalcemia is generally asymptomatic. Patients with mild hypercalcemia often have with only mild hypercalcemia can have significant symptoms such as depression, psychic moans, constipation, abdominal groans, and of course bones and joint pain, which is bones. Neuromuscular manifestations of this disease include paresthesias or tingling sensations, or alternatively neuropathy as it's sometimes called, muscular cramps, weakness, and diminished deep tendon reflexes. CNS manifestations over and above the depression will include malaise, headache, fatigue, intellectual weariness, insomnia, irritability, and depression. A large amount of calcium in the body will result in hypertension, palpitations, PR interval prolongation, shortened QTC intervals, bradyarrhythmias, heart block, asystole, and even an increased sensitivity to digitalis or digoxin. Other hypercalcemia manifestations related to the kidney include polyuria, polydipsia, and hypercalcemic-induced nephrogenic diabetes insipidus, and you may also get kidney stones as a result of the hypercalcemia, hence the stones. And of course, GI symptoms include anorexia, heartburn, nausea, vomiting, abdominal pain. So there's your groans to some degree, weight loss, constipation, obstipation, and of course pancreatitis in approximately 3% of cases. Normocalcemic primary hyperparathyroidism. This generally has very few symptoms. Patients have slightly more atherogenic lipid panels and a higher blood pressure than normal patients, and some symptoms are very vague, example mild fatigue. That's why questioning in these scenarios are extremely important. Hyperparathyroidism during pregnancy. Approximately 67% of women with primary hyperparathyroidism during pregnancy experience complications such as nephrolithiasis, hyperemesis, pancreatitis, weakness, cognitive changes, and a hypercalcemic crisis. Most of the time they have mild hyperparathyroidism where their serum calcium level is less than 2.75 millimoles per liter, and they will generally tolerate pregnancy well. The majority of women with more severe hypercalcemia will suffer worse complications, and the complications, as we've discussed, include nephrolithiasis, hyperemesis, pancreatitis, muscle weakness, and even cognitive changes as well. Hypercalcemic crisis may occur particularly postpartum, so after delivery. Approximately 80% of fetuses experience complications such as fetal demise, preterm delivery, and low birth weight. Hypocalcemia in the infant generally presents as tetany even 2 to 3 months after birth. The diagnosis of primary hyperparathyroidism involves hypercalcemia with an adjusted calcium of greater than 2.6 millimoles per liter, a serum ionized calcium level which is elevated to be more than 1.36 millimoles per liter. You also need to check urinary calcium for diagnosis, right? Because a lot of the time you have hypercalciuria or an increased amount of urine calcium excretion, or it will be normal, right? Primary hyperparathyroidism, the urine calcium is either normal or raised, anywhere between 25 to 75 millimoles per liter. The serum phosphate level will be decreased, so it will be less than 0.8 millimoles per liter. The serum calcium to phosphate ratio will be 2.17, and this will confirm the diagnosis of hyperparathyroidism. Vitamin D deficiency is common, and thus it is something that is prudent to screen for in these patients. Again, elevated serum levels of intact parathyroid hormone can confirm the diagnosis of hyperparathyroidism. Parathyroid carcinoma must be suspected if serum calcium levels are extremely high, that is more than 3.5 millimoles per liter, and the serum parathyroid hormone is almost 5 times the upper limit of normal. Patients with low bone mineral density and an elevated serum parathyroid hormone but a normal serum calcium level should be evaluated for secondary hyperparathyroidism. Parathyroid imaging is not necessary for diagnosis of hyperparathyroidism, partially because it will be very difficult to see. In terms of imaging, which is an extremely important thing for us to discuss, it is obviously worth noting that single benign thyroid nodules are discovered incidentally in nearly 50% of hyperparathyroidism who have had imaging either using an ultrasound or an MRI. The CT and the MRI scanning are not ordinarily required or useful in that matter for initial preoperative parathyroid localization studies, since scanning techniques are less sensitive for identifying tiny parathyroid adenomas. However, for repeat neck operations when ectopic parathyroid glands are suspected, when ectopic parathyroid glands are suspected, MRI is the preferred method and offers better soft tissue contrast than a CT scan and is less adversely affected by post-operative changes in the neck. 3-dimensional titanium 99M scanning is generally what is used to actually localize parathyroid glands. Bone mineral density using a DEXA scan or an X-ray absorptiometry scan is useful in obtaining the amount of bone loss in patients with hyperparathyroidism. Remember that bone loss most commonly occurs in long bones, and the DEXA scan should ideally include 3 areas of the lumbar, spine, hip, and distal radius. Bone radiographs, on the other hand, are not generally required and make the diagnosis of hyperparathyroidism are generally not required to make the diagnosis of hyperparathyroidism. There may be some demineralization, subperiosteal reabsorption of bone, or even loss of the lamina dura of the teeth, which you may sometimes see. I think the bottom line is that scanning and neck ultrasonography can locate the parathyroid adenoma in an effort to improve the outcome and limit the invasiveness of surgery when surgery is required. Parathyroid imaging is crucial for patients who have had prior neck surgery, just to see what is going on there. And in that scenario, like we said before, an MRI is the one in which we would generally go for. Patients with mild hyperparathyroidism should be considered asymptomatic only after very close questioning. And that is because the symptoms are so varied that you must make sure that once you've gone through every single symptom, before you can say for sure that they are asymptomatic. Many will not even notice cognitive slowing or having become so accustomed to the symptoms over many years. You also need to assess blood pressure, BUN, creatinine, and also determine the presence of nephrolithiasis or nephrocalcinosis. It's worth noting that one of the consequences of hyperparathyroidism? It results in excessive excretion of calcium and phosphate by the kidneys. Parathyroid hormone normally causes reabsorption of calcium, right? And of course, hyperparathyroidism leads to hypercalcemia and an increase in calcium in the glomerular filtrate, which then overwhelms the tubular capacity and leads to hypercalciuria. Approximately 5% of patients will develop renal calculi, and there's your stones, your bones, stones, groans, and psychic moans. There's your stones. Excessive parathyroid hormone also results in a cortical mineral decalcification. Decalcification is particularly evident in the wrist and hips, which is why we will obviously use our DEXA scan there at the wrist and the hips, and the distal radius as well, where we sometimes can see it. And remember that this affects long bones as well, so we'll also do stuff like the lumbar areas and the spine, and yeah. Severe chronic hyperparathyroidism can cause pathological fractures and cystic bone lesions through the skeleton, such as osteitis, or also known as osteitis fibrosa cystica, not cystic. It may also lead to pathological long bone fractures due to the fact that, of course, you have bone mineral density lost of the long bones. Urinary tract infections may occur due to the obstruction caused by stones as well as uremia. Pseudo-gout may complicate hyperparathyroidism both before and after the surgical removal of the tumor. Hypercalcemia during gestation produces neonatal hypocalcemia. Chronic kidney disease related tertiary hyperparathyroidism leads to calcification of the skin, and this is where your parathyroid gland becomes autonomous itself and releases larger and larger amounts of parathyroid hormone. You can cause calcification of the skin, soft tissue, and arteries, and that can lead to painful ischemic necrosis of the skin, which can eventually lead to gangrene. That increase in calcium levels can lead to cardiac arrhythmias and respiratory failure as well. Now, one of the things that you can actually treat hypercalcemia with is the use of bisphosphonates. And intravenous bisphosphonates are potent inhibitors of bone reabsorption and can temporarily treat hypercalcemia of hyperparathyroidism. Pamidronic acid, or pamidronate as we sometimes call it, right? This drug causes a gradual decline in serum calcium levels over several days, and the effect may last for weeks to months. It's generally used as a preparation for surgery. Alendronate, which is an oral bisphosphonate, increases bone mineral density in the lumbar spine and hip, but not distal wrist, which we know is one of the places where you will get loss of bone mineral density. Use in asymptomatic patients with hyperparathyroidism and low bone mineral density is where it is suggested you use alendronate. Now, in primary hyperparathyroidism, patients with a vitamin D deficiency require replacement. Aggravation of hypercalcemia generally does not occur when you replace vitamin D. Anywhere between 800 to 2000 international units of vitamin D or more may achieve a serum 25 hydroxyvitamin D level of 50 nanomoles per liter or more, which will reduce the serum parathyroid hormone levels. Secondary hyperparathyroidism, which is usually as a result of chronic kidney disease, requires treatment with calcitriol given orally 0.25 micrograms on alternate days or daily after dialysis. Calcitriol also causes hypercalcemia, so the serum levels of calcium and phosphate must be closely monitored when using calcitriol. Asymptomatic patients. If they are truly asymptomatic, we only need to monitor them. Remember that in order for them to be classified as asymptomatic, we must make sure that we are consistent, that we have been very consistent and very persistent and very thorough in our examination of all of their symptoms, and ensuring that we have been extremely thorough to make sure that they do not have any symptoms. We need to advise them to keep active, avoid immobilization, and drink adequate amount of fluids. Remember that fluids are the first thing that we generally use to try and treat hypercalcemia. So to try and prevent them from getting hypercalcemia, we want them to drink adequate amounts of fluids. In patients who are postmenopausal, we should consider the use of hormone replacement therapy, because this will improve bone mineral density and reduce serum calcium levels as a result. Patients with hypercalciuria, that means excreting a large amount of calcium out in their urine, we should be treating with hydrochlorothiazide anywhere between 12 to 25 milligrams daily. Affected patients should avoid large doses of thiazide diuretics and vitamin and calcium containing antacids or supplements. Serum calcium and albumin levels must be measured every 6 months. Kidney function and urine calcium every 12 months or annually. You need to remember to do your 3-site bone mineral density using your DEXA scan approximately every 2 years. Remember that you must do the distal radius, the hip, the lumbar spine region as well can be considered. And then of course, surgery is of modest benefit in these patients. Other measures that can be considered is raloxifene at a dose of 60 milligrams daily may be given to postmenopausal women with hyperparathyroidism. Propranolol may be useful in preventing adverse cardiac events of hypercalcemia. Parathyroid carcinoma metastases may be treated by radiofrequency ablation, right? And this is a form of interventional radiology. Or arterial embolization, also a form of interventional radiology and not part of the scope of this particular course. Parathyroidectomy for patients with hyperparathyroidism who are symptomatic or have nephrolithiasis or bone disease can be considered. Parathyroidectomy is performed in the second trimester for women who are symptomatic or have high serum calcium levels of more than 2.75 millimoles per liter. For severe hypercalcemia, remember what I told you, the first and most important thing is to use adequate fluids unless they are contraindicated. So normally what we would use is normal saline of approximately 4 to 6 liters given intravenously over the first 24 hours. If they are still asymptomatic after 24 hours and are considered to be adequately hydrated, or their serum calcium levels are still above 3 millimoles per liter, that is when we use permethrinate or pamidronic acid given 30 milligrams IV over 4 hours to obtain the serum concentration that we are looking for. The doses should not be repeated for 7 days, and a reminder that permethronic acid takes 24 hours to start working, so a response will only be noted in 24 hours and the actual drug reaches a trough after 5 to 7 days normally. In terms of hypoparathyroidism, there is essentially acquired hyperparathyroidism, and acquired hyperparathyroidism is most commonly after anterior neck surgery and usually comes as a result of a permanent and usually occurs as a result of some kind of surgery such as the removal of the thyroid gland, for example. Permanent hypoparathyroidism may occur after the resection of multiple parathyroid adenomas as well. Also, it may occur transiently after the surgical removal of a single parathyroid adenoma from primary hyperparathyroidism. All patients undergoing a thyroidectomy and a parathyroidectomy must be observed closely overnight for symptoms of hypoparathyroidism and must be treated adequately. Neck irradiation for parathyroid carcinoma is really a cause of hypoparathyroidism. Another form is the autoimmune hypoparathyroidism, which may be isolated or combined with other endocrine deficiencies, and it's a very rare genetic condition that is mostly found in Scandinavian, Sardinian and Iranian Jewish people. Hypoparathyroidism is most frequent and often occurring and often the only endocrine deficiency. Hypermagnesemia also suppresses parathyroid hormone secretion, and congenital hypoparathyroidism causes hypocalcemia beginning in infancy. The clinical features of this disease include a manifestation of hypocalcemia, which tends to range anything from being very subtle to extremely life-threatening. Patients generally have a reduced quality of life and often suffer from fatigue, irritability, depression, anxiety, cognitive impairment, and even brain fog, as well as lethargy, paresthesias in the circummural areas, hands and feet. More severe manifestations include muscle weaknesses, carpopodial spasms, convulsions, tetany, laryngospasms, and even stridor. Chronic hypocalcemia with hyperphosphatemia can cause calcification in soft tissues such as joints, skin, arteries, etc. Now, the clinical feature that will obviously be noticed is the positive Chauvet-Text sign, and the positive Chauvet-Text sign, is where you will get a contraction of the facial muscles when you tap directly on the facial nerve, which is just in front of the ear itself. Usually you will get a sort of a contraction of the muscles there. Then you get Trousseau's phenomenon, which will result in a carpal spasm of the hand itself when you apply a blood pressure sphygmomanometer cuff to the arm itself. Cataracts may also occur in these patients. Nails will generally be thin and very brittle. The skin will be dry and scaly at times, with fungal infections such as candidiasis as a superinfection, and there may be the loss of eyebrow. And then, of course, deep tendon reflexes will become hyperactive. In general, the serum calcium level is low, and conversely that means that the serum phosphate level will be high. Urine calcium excretion will be low and alkaline phosphatase will be normal. Serum calcium is largely bound to albumin, so hypoalbuminemia, then you will get serum calcium levels will need to be determined. Serum parathyroid levels are usually low or not elevated in the presence of hypocalcemia, and serum magnesium levels must be measured because hypermagnesemia can result in hypoparathyroidism, as we said here. Of course, a radiograph or CT scan of the skull may show basal ganglia calcification, and this is as a result of hypoparathyroidism, and this is where we need to use radiographs and CT scans much more. Of course, we will use CT scans and MRIs and ultrasonography to some degree when we are looking for hyperparathyroidism as well. Bones may appear denser than normal, and bone mineral density is generally increased, which is the opposite of hyperparathyroidism, in which bone mineral density is actually decreased. Slit lamp examination may show posterior lenticular cataract formation, so cataract formation as we discussed before. An ECG may show heart block and prolonged QTC interval, so a prolonged QTC interval, as well as a T-wave abnormality in the presence of hypocalcemia. The complications of hypoparathyroidism largely depend on the duration of the disease. Acute tetany with stridor, which will lead to respiratory obstruction, requires a tracheostomy. It may be associated with autoimmunity causing celiac disease, pernicious anemia, and even Addison's disease. Ossification of paravertebral ligaments may occur with nerve root compression as well. Seizures are common in untreated patients, and hypocalcemia can also cause heart failure and dysarrhythmias as well, or dysrhythmias. Now, the prophylaxis for severe post-operative hypocalcemia. Remember what I told you at the beginning. Those people who are having surgical resections of a parathyroid adenoma, or to remove their thyroid glands, or surgery on their thyroid glands, need to be monitored for overnight after surgery. And of course, post-thyroidectomy hypocalcemia can be detected early by closely monitoring serum parathyroid hormone levels and calcium levels. Serum calcium levels of less than 2 millimoles per liter and serum parathyroid hormone levels of 1 to 1.5 picomoles per liter post-thyroidectomy indicate that the patient is at high risk of developing post-operative hypocalcemia. These patients may be treated prophylactically with calcitriol and calcium. Calcitriol is given at a dose of 0.25 micrograms up to 1 microgram twice a day, with a prophylactic elemental calcium, which is given orally as calcium carbonate with meals anywhere between 500 to 1000 milligrams given twice daily. Emergency treatment of hypocalcemia. The airway must be adequate and must be present. In this scenario, the first thing to do is to give 10% of calcium gluconate. 10% calcium gluconate as 10 to 20 ml IV, which is given slowly until the tetany itself ceases. Then 10 to 50 ml of 10% calcium gluconate may be added to a 1 liter 5% dextrose or a 0.9% saline, which is administered slowly via intravenous administration. The rate should be adjusted so that the serum calcium level is maintained in the range of 2 to 2.25 millimoles per liter, and calcium salts should be given orally to supply 1 to 2 grams of calcium per day. The patient will also require calciferol of 10,000 to 50,000 international units daily for the first 4 to 8 weeks. And hypomagnesemia of less than 0.8 millimoles per liter must also be corrected using magnesium. Right. In this particular scenario, right, acute magnesium sulfate is administered 1 to 2 grams every 6 hours. Long-term magnesium replacement as magnesium oxide tablets may be given as 600 milligrams 1 to 2 times per day, or may be combined as a calcium and magnesium preparation. The maintenance treatment of hypoparathyroidism. Patients with mild hypoparathyroidism may require no therapy but need close monitoring for manifestations of hypocalcemia. The treatment of symptomatic hypocalcemia or serum calcium levels less than 2 millimoles per liter is definitely required. Patients with hypoparathyroidism have reduced renal tubular reabsorption of calcium and therefore are prone to hypercalciuria and kidney stones. If the serum calcium level is normalized with calcium and vitamin D. As a result of that, what you actually want to do is you want to maintain your serum calcium level at a slightly low but asymptomatic range of 2 to 2.15 millimoles per liter, and it is prudent to measure urine calcium via spot urine, which must be less than 7.5 millimoles per liter. Right, maintenance treatment for hypoparathyroidism. Calcium supplements of 800 to 1000 milligrams per day is generally given. Calcium supplementation must be given with meals because this causes less GIT intolerance. Vitamin D is generally required for chronic hypoparathyroidism. The monitoring of serum calcium levels at regular intervals, which is approximately every 3 to 4 months, is required. Calcitriol at a dose of 0.25 micrograms per day up to 2 micrograms per day may be required, but this is short acting. Instead, one could consider the use of ergocalciferol 25,000 to 150,000 units per day because it is stored in the fat and is thus longer acting. Parathyroid hormone is effective for treating patients with hypoparathyroidism but is restricted. Recombinant parathyroid hormone can be used as an adjunct to vitamin D and calcium to control symptomatic hypocalcemia in patients with hypoparathyroidism. Recombinant parathyroid hormone can be given via subcutaneous injection every 1 to 2 days. It's worth noting that maternal hypocalcemia can affect skeletal muscle development of the fetus and cause compensatory hyperparathyroidism in the newborn. Maternal hypercalcemia can suppress fetal parathyroid development resulting in neonatal hypocalcemia. It is important to be cautious when using phenothiazine drugs in patients with hypoparathyroidism because this can result in extrapyramidal side effects in hypocalcemic patients. Additionally, furosemide may worsen hypocalcemia. And with that, we've come to the end of this particular lecture, and I'd like to thank you for your time.